From the foundation for the collaboration two session, I will invite you the first presenter. One from students is here. We will have an 8-minute presentation for each case and 2-minute discussions for the discussion, and then afterwards 2 minutes more of questions from the audience if you want to make any questions.
Perfect. Yeah. I want you all to take a moment and think about why are we actually here? And some of you may think about the beach, and that's the reason why you're here. But of course, it's not only the beach. We're all here to improve outcomes for APD patients in clinical practice. And we want to do that by sharing our research and by implementing this research into clinical practice for our patients. But we have a problem regarding this. Because if you take a look at surgical RCTs, they are the highest level of evidence, but surgeons only adhere to these recommendations by the RCTs in less than 50% in clinical practice. So even though we do a lot of research, we do have a problem with the implementation. So when we know a strategy is better, how do we ensure we actually use this strategy? You would think you would think we'll just do it. But unfortunately, that seems a bit harder than anticipated.
You don't have to screen it.
So regarding pancreatic cancer, the incidence has been increasing the past couple of years. And we've had new insights in treatment strategies, such as the use of neoadjuvant chemotherapy and the introduction of FOLFIRINOX. But regardless of these new strategies, the overall survival in nationwide studies only increased from 3 to 4 months. We think these minimal effects of these strategies are due to guideline non-compliance, slow uptake of new treatment regimens, and undesired practice variation. Regarding the guideline non-compliance, the study we investigated shows that 5 quality indicators 6 years after the implementation of the guidelines did not show improvements over time. Additionally, the use of FOLFIRINOX varies a lot among centers in the Netherlands, and we see no direct clinically relevant improvements in overall survival nationwide. Thereby, we see a lot of undesired practice variation. If we take a look at metal stents, and we believe are superior than plastic stents, the use ranges from 0 to 77% among centers as well. So we investigated all outcomes in the Dutch pancreatic cancer project, which started in 2013, and we've evaluated nationwide outcomes in all different registries. And we were thinking, what should we definitely improve? What's already in the guideline? And this resulted into 3 best practices. We think that everybody in every center should use optimally chemotherapy. We need optimal use of pancreatic enzyme replacement therapy and optimal use of metal stents for biliary drainage. So the aim of this study was to improve nationwide outcomes by the implementation of these best practices. So we used study design a stepped wedge cluster randomized control trial, which was performed nationwide. This obviously sounds a little bit complicated, but I will explain it to you. We included all pancreatic cancer patients in the Netherlands from 2018 until 2020. And if you take a look at the left side, you see all the clusters. That are the pancreatic surgical center and the referral networks. Down you see the time period, and each box consists of 6 weeks. So at the start of the trial, in orange, all centers are in current practice. That means they are in usual care. They do things that they are used to. Then you see the first center going into the gray area, which is the watching period. During the wash-in period, we advocated for our best practices. So we gave education, feedback, and reminders on giving chemotherapy to all patients that need it, pancreatic enzyme replacement therapy, and metal biliary stents. Then afterwards, the center is in blue, the best practice. So in the results, we compare the patients in current practice with the patients in best practice, which are half of the patients at all times. So the primary outcome was 1 year survival, and secondary, we investigated the implementation of our best practices and quality of life. So for our analysis, we imputed baseline characteristics but not outcome, and we used mixed factor models to adequately investigate our primary outcome. So we corrected for cluster and also for calendar time to make sure we actually see the outcomes of our intervention and not just normal time. We included over 6,000 patients, of which half in current practice and half in best practice. And the median age was 72 years old of all patients. Also, it's important to know that the majority of patients in both groups are the metastatic patients. We often forget this because we talk a lot about the resectable patients, but 62% of patients are the metastatic ones. So the primary outcome, 1 year survival. I was hoping to tell you something differently, but unfortunately there was no difference in 1 year survival among both groups. But interesting to see is that the overall survival is even less than 4 months, and I think that's something we should take into account. If we then look at the implementation of the best practices, the first thing was to improve chemotherapy in the patients. If we then look at the resectable patients or borderline resectable, we see that the neoadjuvant therapy in all non-metastatic patients stayed the same as in both groups. The adjuvant therapy raised a little, but it was not statistically significant. Taking into account the palliative chemotherapy, you see that this increases from 24% until 30%, and this was statistically significant. Two additional best practices, the use of metal stents and pancreatic replacement therapy also increased with 10%. So from 73 until 83 for the metal stents, statistically significant, and as well for the pancreatic replacement therapy from 34% until 45%. Quality of life, unfortunately, was the same for both groups, but this was only investigated in about 10% of patients willing to participate in the quality of life questionnaires. So the conclusion of this trial, unfortunately, the BACA-1 study showed no increase in 1 year survival and quality of life. But important to know that in the majority of best practices, we succeeded to enhance implementation. But why didn't we increase the 1 year survival, even though the best practices are implemented quite sparingly? Well, our chemotherapy targets were not reached. We were trying to get 70% of patients receiving adjuvant chemotherapy, but this was only 52%. And we wanted 40% of patients to get palliative chemotherapy, and this was only 30%. So this is very unfortunate. We also have to take into account what I already mentioned in the survival curve, is that the survival was very poor in all patients. Median survival was only 4 months, and if we take a look at our results, 61% of patients do not receive any kind of tumor-targeted therapy. And that also has to do with the metastatic pancreatic cancer patients, which comprise a large part of the group. If you only look at the Kaplan-Meier for the metastatic patients, median survival is only 2 months. So for the second BACA trial, I think we've learned a lot from this trial, showing our real-world data. But we have to investigate, is it really realistic to improve outcomes in all patients? Or should we maybe focus more on patient selection on the patients who actually need it? Thank you very much. Happy to answer.
Thanks for the wonderful presentation. Your discussant will be Dr. Matt Weiss from Northwest Health.
Congratulations to you and your team on another well-designed randomized trial, and very eloquently presented today. And congratulations on your award. We can see it's well deserved from the Stephen Stotsky Award for pancreatic cancer. So I think you shouldn't be too hard on yourself in terms of not achieving your primary endpoint here. I see this as two main issues with best practice guidelines. Number one is defining what best practice guidelines are. And then number two is, once you know it, how do you implement best practice guidelines? So a lot of people in this room work in unique medical systems. I work in the New York metropolitan area, which is about the size of the Netherlands, both geographically and population-wise. And we struggle with both, coming up with what really we define as the best practice guidelines. And then once we all agree upon it, how do we implement it? I think you've shown in this trial that you can at least implement best practice guidelines. And your endpoint of 1 year overall survival is difficult, right? Because it looks like from a chemotherapy standpoint, we're actually doing a pretty good job beforehand. And so by manipulating, improving pancreatic enzymes and biliary stents, it was designed to see a difference in 1 year survival. Plus the fact that a lot of these patients, let's be honest, are not living a year, no matter what we do. So 2 quick questions. Number 1, how did you define your best practice guidelines in this group? Because I think it can be difficult and challenging to really identify, who should get neoadjuvant therapy, who shouldn't. We debated this yesterday for a resectable pancreas cancer. So how do you define best practice guidelines? And number 2, if you were to do this over again, what would your primary endpoint be? Would it still be 1 year overall survival? Thank you.
Thank you very much for your kind words and good questions as well. I completely agree with actually almost everything that you say. And regarding the best practices, we identified them by using the national guidelines. So it were all things which were already in the national guidelines. And we discussed it in the meetings of the Dutch Pancreatic Cancer Group. But to be completely honest, I think we used systematic reviews to get the available evidence, but there was no core definition of what should be a best practice or not. So I think point of discussion. Regarding the primary outcome, we've discussed about this a lot as well, but I think the main reason why we decided on 1 year survival as a primary outcome is that this is applicable for all patients. So the use of method stents is only for patients who undergo biliary drainage, and we want to include all patients and also not all patients who undergo systemic therapy. So that's why we chose for this primary endpoint. And even though I think it may be, we did not reach it, and I don't know if it's realistic that we aim to reach it, it is very informative because I think the real world data which shows us that the survival is very poor also gives us more, the necessity to do something about it. So I think I would choose it again.
Dr. Stantz, can I ask another question? It seems like the implementation of chemotherapy, getting that to patients is a barrier. As you design your next trial, are you guys doing anything with regards to focus groups or going back and interviewing providers and patients to understand what those barriers are?
Yeah, definitely. We currently already set up a trial in which we asked the treating physicians on reasons why patients do not receive the chemotherapy, if it was more the choice of the physician of the patient. And we didn't think yet about a focus group, but I think it's a really important thing and we should include it in our next trial.
Additional questions? Really nicely presented. Thank you.
Thank you.
So our next talk is entitled Is it Time to Pop the Pancreatic Fistula Risk Score, presented by Dr. Roche from Indiana University. The discussant will be Pamela Liddell from Moffitt Cancer Center. Good afternoon.
Good afternoon. I would like to thank the HPV and the program committee for the opportunity to present our work today. I have nothing to disclose. The only thing is that it's going to be controversial, especially when I see the crowd in front of me. So postoperative pancreatic fistula, as everybody knows, it's a common complication after Whipple. It ranges from 3 to 45% depending on the series, and it's well defined as a drain amylase at least 3 times the upper limit of normal on or after postoperative day 3. The grading system has changed over time, and the most recent one is from the International Study Group 2016, defining clinically relevant pancreatic fistula as pancreatic fistula grade B and C. Now, I'm going to go very quickly. We all know pancreatic fistula after Whipple has a major impact both on the patient and on society. It's associated with an increased length of stay. It's associated with a decreased survival because less patients are actually getting adjuvant chemotherapy. It's associated with increase in healthcare costs. And finally, a decreased quality of life for our patients. Now, the fistula risk score, so everybody in this room also knows, it was published in 2013 by Dr. Callery in the Journal of the American College of Surgeons. It includes 4 factors: the gland texture, the pathology, the pancreatic duct size, and the estimated blood loss, and ranges from 0 to 10 points. And it's been well described in many, many studies that there's a linear correlation between the fistula risk score and the clinically relevant postoperative pancreatic fistula rate. And so it's just one example on the right of a paper published in Annals of Surgery in 2016. Now, more recently, the post-pancreatectomy acute pancreatitis, kind of a new entity that was defined for the first time in 2022. And published in Annals of Surgery based on the definition from the International Study Group. It's defined as a sustained hyperamylasemia of at least 48 hours post-operatively and clinical symptoms and radiologic changes of acute pancreatitis. And the grades are mirroring the grades of postoperative pancreatic fistula as the need and the invasiveness of management for that pancreatitis. Now, the definition is kind of a moving target, and we've discussed that yesterday already. There's many questions, especially the role of imaging in the definition and the specificity of the symptoms in the immediate post-op period. Now, the aim of our study was to determine the relationship between clinically relevant postoperative pancreatic fistula, the fistula risk score, and postoperative pancreatitis. That name popped because I didn't define it exactly like it was defined by the International Study Group. And we hypothesized that postoperative pancreatitis was an independent predictor of clinically relevant postoperative pancreatic fistula and added predictive value to the fistula risk score. From 2015 to 2020, we prospectively including all consecutive work operation at our academic institution and used the 2016, I guess 2015 was the last time we used the former definition, but starting in 2016, we used a new definition of pancreatic fistula and a new grading. And so I'm going to take a small break and talk about our definition of postoperative pancreatitis because it's slightly different. So we studied postoperative day 1 serum amylase as raw data and mini cutoff 1 time, 2 times, 3 times the upper limit of normal, and found that the only one that was actually statistically significant was a postoperative day 1 amylase of 2 times the upper limit of normal. Now, I will say that we don't consider the symptoms as specific as they are described before, because I don't know if you know a patient who starts day 2 of a Whipple that doesn't have pain. I wish I could meet that person. And a lot of them are tachycardic for whatever reason. So I don't think that should be a major part of the definition. As for the radiological finding, we don't scan our patient routinely in the immediate post-op period. So we didn't feel that should be part of the definition either. So that's why I describe postoperative pancreatitis as POP, as an acute inflammation of the remnant pancreas on post-op day 1 with a hyperamylasemia of 2 times the upper limit of normal, which is 172 at our institution. We included 496 patients in our study with a sex ratio of 1, a mean age of 65, 70% were operated on for cancer, 30% for benign disease, most likely chronic pancreatitis. 13.5% had clinically relevant postoperative pancreatic fistula, broken down as 10.3 of grade B and 3.2 as grade C. Now, we first reviewed our data and checked the fistula risk score variables, and not unsurprisingly, the soft pancreas, the surgery for non-PDAC, non-pancreatitis, the small duct, and the high EBL were associated with an increased risk of clinically relevant postoperative pancreatic fistula. It's not earth-shattering, everybody knows that. Now, when we excluded all the fistula risk calculator variable, because they're well established and well defined, we did the multivariable analysis and found that our definition of postoperative pancreatitis, so a postoperative one serum amylase of at least 2 times the upper limit of normal, was the only independent predictor of clinically relevant postoperative pancreatic fistula, with an odds ratio of 2.5. Now we calculated postoperative pancreatitis and fistula risk score, and the higher the score, the higher the rate of postoperative pancreatitis, or the opposite, the higher the rate of postoperative pancreatitis, the higher the score. So we know that they go hand in hand. Now we thought, what if we actually add the postoperative pancreatitis to the fistula risk score? Is it adding something, or are the variables just covariate together and it's not going to add anything to an already well-established score? So we created a 12-point score by adding postoperative pancreatitis and weighing it with 2 points. We found that the ROC curve had an AUC of 0.75. And then we measured the accuracy of the fistula risk score and fistula risk score plus the postoperative pancreatitis in predicting postoperative, clinically relevant postoperative pancreatic fistula. And we find that the fistula risk score itself was extremely good, with a coefficient of correlation of 0.78. But when you add the postoperative pancreatitis, you reach a coefficient of correlation of 0.92. So even if all the variables actually go hand in hand and covariate, there's still something added by that postoperative pancreatitis that is not explained by the fistula risk score variables. So in conclusion, clinically relevant postoperative pancreatic fistula is a common complication after Whipple. In our study, it was 13.5% and has multiple implications for patient and society. Postoperative pancreatitis is an independent predictor of clinically relevant postoperative pancreatic fistula. The addition of postoperative pancreatitis to the already well-established and well-validated fistula risk score improves the accuracy of the score. And so we feel that the new score, or at least adding and taking into account postoperative pancreatitis, can help with mitigation strategy and optimization of perioperative management. So I'm going to quote Dr. Zromsky, who always said there's like the standard pathway and this NRAS pathway, no rush after surgery pathway. Thank you very much for the attention. I'll be happy to take any questions.
I just want to say that I really enjoy going through your slides. And I always call these things God's when like things come across your desk or across your computer just at the right time when you needed it. So it just so happened that your slides came at the same time I had a patient that had a serum amylase of about 500 and drain amylase of 3,000. And I'm thinking to myself, am I going to end up with a clinically relevant pancreatic fistula in the end? Fortunately, I did not. The drain amylase themselves resolved and the serum amylase after 48 hours also dissipated. But in 2021, Nick Zromsky and Dr. Gianni, I believe at the SSAT, debated as to whether or not there is
Right there.
oh, there he is. Hey. As far as you get, whether or not this the whole thing of the postoperative pancreatitis is even clinically relevant, right? In my case, not so much. And so, but your group is suggesting that it actually may be a factor and may be a reason for postoperative pancreatic fistula. And it's always amazing to me how our GI endo colleagues can go and they can do a fine needle aspirate with a 22 gauge needle or an ERCP, and they get bad pancreatitis, and even it could be force altering and treatment altering for these patients. Yet during the surgeries, we manhandle the pancreas, we cut it, we bogey it, we stab it, we put needles through it. And for the most part, most of those patients don't end up with pancreatitis, right? Why do patients doing endo procedures sometimes get it, but we do all this to the patients and they don't? So one of my questions to you is like, what are some of the factors that you would think of that would predict the development of postoperative pancreatitis? And I think we all have to be realistic. I know my colleagues, they're at fault as much as everybody else. They check they check drain amylases, but nobody checks the serum amylase. I might be one of the few people that actually does, because the definition is 3 times your serum. So if you have an elevated drain, you would want to know what your serum amylase is, whether it's clinically relevant or not. But I think a lot of us don't even know what the true incidence is. And then just a couple of comments. One is I didn't know if the factor of how you put your anastomoses together factored into the development of post-op pancreatitis, PJ, whether or not it was dunking. And then I always love the use of studs. So some people use them or think about using them to prevent post-op pancreatic fistulas. I've never used it in that way after Chuck Ballmer basically, I think, was standing up there and says, don't put any stents in your pancreatic ducts. But I will tell you that soft pancreases, small ducts, scare me. And for those, I will leave something across, not so much to prevent a pancreatic fistula, but I worry about the postoperative edema and the structuring and the narrowing of the pancreatic duct causing pancreatitis. So I know that it's not, but if you could just comment on some of that, I'd appreciate it.
Of course. So your first and third question probably go hand in hand. There may be a lot of factors for postoperative pancreatitis, local ischemia, some techniques, some perioperative management. We don't know if increased the fluid in the operating room causes some edema. Sometimes we see it so subjectively we feel it's happening, but I don't know if that works. There's been a lot of study, but there's still a lot of study that need to be done from a local standpoint to see the changes that happen. For the technique that we use, and I'm not going to make friends there, but so most surgeons I use do a standard 2-layer with a duct to mucosa. Me and another surgeon are doing a Bloomgard Kelly, so we're doing transfixiating sutures. So we don't feel that there is more pancreatitis in that setting, but again, it's just like our experience. It's not a controlled trial, so unclear. What was your other question? The stent. So the stent is not recommended. We're doing very occasionally when we feel that the duct is extremely small, the gland is extremely soft, and even tying the suture, you can see that this ripping apart. So, and it would be an external stent most of the time. We've seen some elevation in the serum amylase postoperatively in that setting, but unclear if it's from the stent itself or from the gland that's soft with a small duct. So.
Henry Pitbucker is very nice, Alex. The original fistula restore is now one of multiple restores. Have you had an opportunity to compare your suggested new restore with some of the others? There's the one from the Netherlands, the modified one from the Netherlands. When I do a lot of reviewing, it seems like every month I get a new paper about a new risk score. Lots of times the worry is, we have to have all this information pre-op, and the serum amylase we don't get till post-op. I'm a big believer in serum amylase, but to your point, we have data from this group, post-op, that only 15% of people are even checking serum amylase. Now we need a whole lot more to actually do that. So how do you compare with others, and how do we get everybody to check serum amylase?
So we haven't compared. We have compared to the original one, but not to the others. But that's a great point, and we will. As for the serum amylase, I'm going to plug in with the MD Anderson. So I got help, and they're working on pathways, and we're going to follow their lead and do standard paths that I use well with checking serum amylase on everybody. And we started already a couple of years ago to do it routinely on everybody. But I don't know if I can convince the entire room. That would be amazing. But I know there would be a lot of people that do it like on all their patients. So I know that originally people were like, postoperative pancreatitis and everything. I truly believe that this is it. We've had really bad cases, even having pancreatitis. So it's real, and it's pretty bad. So.
Very much. Information commission of visiting the classes.
Sorry.
Role of post-operative diabetes. Dr. Smith, Center. The discussion will be Dr. Smith.
I'd like to thank my collaborators listed on this slide, as well as the HPBA for the opportunity to present our work. We have no disclosures. Mucinous cystic neoplasms, or MCNs, of the pancreatic body entail or largely asymptomatic incidence of malignancies. With the increase in utilization of high-resolution imaging, there has been a concomitant 30% increase in the identification and resection of these incidental pancreatic cysts, which has, however, not been mirrored by an increase in identification of malignancy or an improvement in overall survival, largely due to the low malignancy potential. Current guidelines recommend resection of MCN in surgically fit patients, particularly those with high-risk features. Resection typically includes a distal pancreatectomy, oftentimes laparoscopic, with or without a concomitant splenectomy. It's a generally very well tolerated procedure, though it's not without complications and potential long-term sequelae. Rates of postoperative diabetes development following distal pancreatectomy have been estimated upwards of 30% in the first postoperative year, which do pose a significant healthcare and financial burden. So given their recommendations for resection of MCNs, coupled with the high risk of postoperative diabetes, we sought to evaluate both the clinical and the economic implications of laparoscopic distal pancreatectomy versus continued surveillance in MCNs of 2 centimeters with no high-risk features through a formal cost-effectiveness analysis. To address this question, we built a probabilistic Markov computer microsimulation model that tracks hypothetical subjects from the time of diagnosis through the subsequent 10 years. At the time of diagnosis, hypothetical subjects could be assigned to laparoscopic distal pancreatectomy or continued surveillance. Those who underwent distal pancreatectomy could experience postoperative complications, which included surgical site infection or postoperative pancreatic fistula. And those who were assigned continued surveillance could experience MCN progression, at which point they would switch to operative intervention. Diabetes incidence could occur at any point in the model with an increased incidence postoperatively, and then death could also occur at any point. We adopted a societal perspective, discounting cost as well as quality adjusted life expectancy at 3% annually. Our outcomes included quality adjusted life years or QALYs, which represent the proportion of 1 year that you're in perfect health. Costs, which are presented in 2021 US dollars, and incremental cost effectiveness ratios, or ICERs, which are defined as the increase in cost for the increase in benefit, or the change in dollars for the change in QALYs. Strategies that increase costs while decreasing the benefit are term dominated, and we evaluated subjects for the first 10 years following MCN diagnosis. We compared all of our ICERs to establish willingness to pay thresholds, which is the amount societies are willing to pay for medical intervention. We used a threshold of $100,000 per QALY, which is in accordance with current US societal norms. We evaluated a cohort with a mean age of 45 and no prevalent comorbidities at the time of diagnosis. Through sensitivity analyses, we varied the age from 35 to 65 in 5-year increments, and subsequently repeated all analyses for a cohort that had pre-diabetes at the time of MCN diagnosis. Those who were assigned to surveillance could progress with a 6.25% progression to operative intervention of MCN over the first 5 years following diagnosis. Surveillance was inclusive of an endoscopic ultrasound or MRI, both with an office visit. We applied the cost of an EUS at month 6, an MRI at month 12, and then alternated annually thereafter. This slide shows the operative characteristics, including the likelihood of postoperative complications, associated cost, quality of life multipliers, and mortalities. Utility multipliers represent decrements in quality of life associated with that health state. So multiplier 0.94, for example, is a 6% decrement in quality of life for the duration of that health state. We assume a likelihood of 12.5% for a clinically significant postoperative pancreatic fistula and roughly 3% for surgical site infection. The cost of laparoscopic distal pancreatectomy was almost $44,000, which included operative costs as well as index hospitalization. And the cost of a postoperative pancreatic fistula included the additional hospitalization as well as any interventional costs. Utility multipliers for distal pancreatectomy and surgical site infection were applied for the first 30 days. And then postoperative pancreatic fistula had a significant utility decrement for the first 30 days following diagnosis, and then a minor though persistent decrement for the subsequent 5 months. The incidence of diabetes was dependent on the postoperative month, with an increased incidence early in the postoperative course. There is a 3 and roughly 9% incidence of postoperative diabetes development in the no diabetes cohort and pre-diabetes cohort immediately following surgical resection, which is compared to a less than 1%, roughly 1% incidence of diabetes in respective cohorts who did not have a distal pancreatectomy. We performed extensive deterministic and probabilistic sensitivity analyses to understand the impact of uncertainty in our input parameters on our outcomes of interest. Through probabilistic sensitivity analyses, we varied several variables concurrently over defined distributions and evaluated the percent at each willingness to pay threshold where each intervention was the preferred strategy. These are our base case results in a cohort with no diabetes at the time of diagnosis. Surveillance was associated with 6.5 qualities. Laparoscopic distal pancreatectomy increased the associated cost while decreasing our quality adjusted life expectancy and was therefore term dominated in the base case scenario. 7% of the operative cohort progressed to diabetes by the end of the first postoperative year. Here are the results of a probabilistic sensitivity analysis. On the x-axis, we have willingness to pay threshold, which is varied from $50,000 to $200,000 per quality. The y-axis represents the likelihood of cost effectiveness at each one of these willingness to pay thresholds. Our pink squares are a surveillance cohort and blue triangles are the distal pancreatectomy cohort. At our base willingness to pay threshold of $100,000 per quality, just over 60% of the time, surveillance was the preferred strategy, which did not significantly change when we increased our willingness to pay threshold. For reference, if these two strategies were equivalent, the line would be overlapping. We repeated our analyses with a cohort that had prediabetes at the time of MCN diagnosis. Similarly, distal pancreatectomy increased cost while decreasing our quality adjusted life expectancy and was again dominating the base case scenario. Almost 20% of the operative cohort progressed to diabetes by the end of the first postoperative year. We have similar results of a probabilistic sensitivity analysis, again, willingness to pay on the x-axis and likelihood of cost effectiveness on the y-axis. We see that roughly 90% of the time at a willingness to pay threshold of $100,000, surveillance is the preferred strategy, which does not significantly change when we increase the willingness to pay to $200,000 per quality. Our results should be viewed within the context of certain limitations. As with all model-based evaluations, we did combine multiple data sources in order to derive the necessary model inputs. We did extensive sensitivity analyses to understand kind of how those varied and how our outcomes changed. We didn't see any significant changes. Data on the natural history of MCN is limited, and so our estimates on progression are based on random IPMNs. We did vary independently just the progression of MCN within the model, anywhere from 0% to 20%, and didn't see any significant changes in our outcomes. There's also little known on the long-term incidence of diabetes following distal pancreatectomy. Our estimates are based on institutional data for the first postoperative year, which show that about 75 to 80% of patients who do develop diabetes do so within the first 3 postoperative months. So it's likely that we're capturing the majority of these patients, but it could be an underrepresentation. In conclusion, resection for MCNs measuring 2 centimeters without any high-risk features decreases quality as well as increasing cost compared to just surveillance alone. The likelihood of postoperative diabetes, particularly in those who have prediabetes at the time of MCN diagnosis, prohibits overutilization of surgical intervention from being a preferred strategy. And we should consider the incidence of postoperative diabetes when we're making recommendations and guidelines on resection for MCN. Thank you. I'm happy to take any questions.
As a probabilistic Markov modeling to help answer a common and very important question in clinical practice, namely when to operate, whereas they conclude not operate on healthy young people with small presumed MCNs lacking high-risk and features. The authors importantly also delve into the long-term risk of developing diabetes following laparoscopic distal pancreatectomy, and have concluded that we're all operating too much, resulting in lower quality adjusted life years and causing increased healthcare costs and creating far too many long-term diabetics. In the United States, 2.5% of the general population harbors chronic fixes, and by the time of 70 or older, 40% will have this, thereby representing a significant public health challenge if we plan to operate on all these patients. MCNs only account for about 10% of these cystic lesions, occurring predominantly in women, usually in the mean age of 48, and most commonly occur in the pancreatic body's tail. The presence of ovarian stroma and lack of communication with main pancreatic duct are critical distinguishing features between MCN and branch duct IPMN. However, importantly, only a final pathology report truly confirms the diagnosis. Cyst fluid analysis may help improve the differentiation, but it's not foolproof. Next-gen targeted sequencing may help, but still not universally available. The risk of MCN harboring an invasive carcinoma, which is the basis of your paper, ranges from 9.9 to 39% in various series. The Central Pancreas Consortium concluded that male sex location in the head and neck, increased size, solid component or mural nodule, and pancreatic ductal dilatation are harbingers of malignancy, making the decision to operate easier. However, the features are lacking in many. In addition, MCNs without invasive carcinoma have no risk of recurrence and therefore do not require surveillance, whereas those with invasive carcinoma have a 25% risk of recurrence and should be followed with pancreatectomy as if they're pancreatic cancer. Clearly, this is a vastly different connotation in terms of healthcare utilization cost. Finally, and uniquely, the authors have defined an estimated increase in development of diabetes over 10 years in both non-diabetics and pre-diabetics, and the results are eye-opening. I would say in my practice at Medical College of Wisconsin, if I have a young, healthy female with an asymptomatic 2-centimeter cyst, I'll obtain baseline labs, get an MRI, MRCP, looking for the characteristics of the cyst and whether there's communication with the pancreatic duct. I will then obtain an EUS-FNA, looking specifically at cyst anatomy and presence or absence of mucin. If these tests are lack high-risk features, as we've discussed, then I'm likely to grow. And I'll survey it initially 6-month mark and then annually after 5 years, and longer thereafter. I have several questions. In regards to your methodology, you stated that the inputs to your models were based on best available data, yet the knowledge of the natural history and progression of MCN is somewhat limited. What effect did the following have on your modeling? The assumption that the risk of MCN progression is similar to branch duct IPMN. One would think it might be closer to main duct IPMN. That the cost of postoperative pancreatic fistula from a laparoscopic distal pancreatectomy were the same as a Whipple and took 6 months to resolve, and that the cost of SSI were extrapolated to cases potentially considered contamination, such as colonic cases. Secondly, do you have your institution's data relative to risk of MCN progression, which is surveillance, and the development of diabetes post-lap distal? Finally, can you tell us how you manage these patients and how you survey them over time? Thank you. I would like to thank you for allowing me to review your paper in advance of the meeting and this very important and practical contribution to the literature.
Thank you for those comments and questions. To your first question, we did estimate the incidence of progression based on branch duct IPMNs, just based on, like you said, the kind of best available data that we have. We estimate our base case at 6.5% over the first 5 years following diagnosis. If we change that rate anywhere from 0 to 20%, it doesn't actually change our outcomes. We did a threshold analysis to evaluate what is the value that we have to see in progression for operative intervention to be the preferred strategy over 50% of the time. And that rate is upwards of 35 to 40%, which means that clinically, roughly 40% of your patients that you are initially surveilling have to switch over into an operative arm. So the progression rate didn't significantly alter kind of the results of our analysis. You also asked about the cost of postoperative pancreatic fistula and surgical site infection. We find that in our results, particularly with our probabilistic sensitive analyses, cost is not the main driver of the results here. It's actually the quality of life component. So we can change the cost of postoperative pancreatic fistula, we can change the cost of surgical site infection, and it doesn't really significantly change what we're saying in terms of what is the preferred strategy at these willingness to pay thresholds. We look at the data that we use for our quality of life multipliers are from published literature that say that there is a significant reduction in quality of life for postoperative pancreatic fistula in the first month, and that's sustained for 6 months. When we assume that the quality of life decrement is only persistent for 2 or 3 months, because that decrement is so minimal in comparison to a kind of a perfect health state, it's 5% decrement over 3 months over the course of 10 years. It also doesn't significantly change our results. We do see a difference if we assume that the quality of life decrement that's associated with the postoperative pancreatic fistula in the first month, it's a pretty significant decrement. We say about 35%. If that is lower to only 10 to 15%, then operative intervention is more likely to be cost effective at higher willingness to pay threshold. So we're saying currently it's a likelihood of roughly 30% at 200,000. If we assume that that quality of life decrement is quite minimal for the first month, then it raises to about 30%. To your second question regarding our own institutional data on MCM progression and diabetes, we don't have institutional data on MCM progression for those that we are currently surveilling. That's something we will certainly look at. And all of the data regarding diabetes incident is actually from our own institution. We published about 2 or 3 years ago about diabetes incidents in both Whipple's and distal pancreatectomies. We found that there's a pretty significant likelihood of diabetes in the first postoperative month, and about 80% of those will develop it in the first 3 months postoperatively.
Thank you. Very nicely presented. Our next presentation entitled Preoperative Therapy Confers Survival Advantage in Early Stage Pancreatic Cancer, presented by Dr. Paul Bouchard from the University of Rochester. Our discussant is Dr. Qingwen Zhang from MD Anderson.
Hi, my name is Paul Burchard. I'm a current general surgery resident and research fellow at the University of Rochester, where I worked in collaboration with the Emily Winship Cancer Institute on this project, where we're looking to identify whether the treatment sequence influences survival in early stage pancreatic cancer. We have no funding to disclose. As we know, pancreatic cancer carries with it a very dismal prognosis. That prognosis has a 5-year overall survival of all comers of around 12%. That went up 1% this year, and improved slightly with multimodal therapy up to around 20%. And that includes patients who undergo surgical resection. However, through multiple clinical trials, we've seen that of patients who undergo upfront surgery, about 40% are ultimately unable to receive any adjuvant therapy due to a variety of reasons: disease progression, surgical complications, etc. These trials listed here are many trials that have now been investigating the therapeutic sequence in early stage pancreas cancer, focusing on borderline resectable and resectable disease. And there have been promising results regarding neoadjuvant therapy and perioperative therapy in particular, with the long-term findings of pre-op PANC 1 and now pre-op PANC 2 is ongoing. But some of the results have been mixed in the other trials, which led us to question whether there are other variables that should be considered preoperatively in these patients. We've done a previous study that was published recently looking at the impact or the prognostic value of CA19-9 in these early clinical stage pancreas cancer patients. And we did indeed find a prognostic value where CA19-9 less than 98 was associated with improved survival in both early clinical stage patients, with the blue curve demonstrating a lower CA19-9 level. And also not shown here, we demonstrated that surgical resection in these patients conferred a survival benefit as well, as you would expect. This led us to look at those patients who underwent surgical resection and the treatment sequences that they received for this early stage clinical stage pancreas cancer based on their varying CA19-9 levels. To do so, we performed a retrospective review through the NCVB, similar to our prior study. And in this, we did a propensity score match analysis with clinical stages 1 and 2 combined and looked at the treatment sequence based on the CA19-9 level. In that particular analysis, we compared perioperative therapy with neoadjuvant therapy and adjuvant therapy. We then subdivided these groups by clinical stage, looked at surgery alone and the 3 additional therapy cohorts. We included those patients with early clinical stage disease, those who underwent definitive surgical resection, and excluded a large number of patients who had missing criteria or underwent surgical procedures for palliative intent. Initially, our first screening identified 380,000 patients with pancreatic cancer. Ultimately, after including our inclusion-exclusion criteria, we were left with 32,000 evaluable patients. This is the propensity score match analysis where we combine clinical stages 1 and 2. The red curve represents perioperative therapy, the blue is neoadjuvant, and the green is adjuvant therapy. And you can see with CA19-9 levels less than or greater than 98, perioperative therapy appeared to confer a survival advantage relative to both neoadjuvant and adjuvant therapy. Whereas CA19-9 greater than 98 showed a survival advantage over adjuvant therapy alone. Multivariate analysis of those patients with these combined clinical stages in CA19-9 less than 98 demonstrated a large number of variables that are independently associated with improved survival that are listed here. Importantly, the therapeutic sequence analysis did demonstrate indeed that perioperative therapy conferred a survival advantage with respect to adjuvant therapy and neoadjuvant therapy alone with a CA19-9 less than 98. Again, looking at the multivariable analysis with CA19-9 greater than 98, many variables associated independently with overall survival that are listed here. And with our focus, perioperative therapy appeared to again demonstrate a survival benefit over adjuvant and neoadjuvant therapy, while neoadjuvant therapy demonstrated on a separate multivariate analysis survival advantage over adjuvant therapy alone. We then subdivided by the clinical stages. The propensity score analysis was done initially because there was a large size discrepancy between these cohorts, as you can see here. But through this subdivision analysis, the clinical stage 1 patients with CA19-9 level less than or greater than 98 appeared to show a survival advantage again with perioperative therapy, while neoadjuvant and adjuvant therapy had very similar survival characteristics, and any multimodal therapy was better than surgery alone. The multivariate analysis of the therapeutic sequence indeed found that perioperative therapy showed a survival advantage with CA19-9 greater than 98 with respect to adjuvant therapy and surgery alone, but no difference compared to neoadjuvant therapy in either CA19-9 cohort, and those with a CA19-9 less than 98 did not appear to show a survival advantage in perioperative therapy compared to adjuvant therapy. Neoadjuvant therapy on a separate analysis was no different from adjuvant therapy in either of these cohorts. When we looked at clinical stage 2 pancreas cancer, we again saw this same trend that we've seen throughout. The perioperative therapy was associated with survival benefit compared to neoadjuvant and adjuvant therapy, and any multimodal therapy conferred a survival advantage over surgery alone. But neoadjuvant therapy began to separate out from clinical stage 2 greater than 98 compared to adjuvant therapy here. And the multivariate analysis confirmed that perioperative therapy demonstrated an independent association with survival benefit for clinical stage 2 pancreas cancer with CA19-9 less than 98 and greater than 98 with respect to adjuvant therapy, and demonstrated survival advantage over neoadjuvant therapy with a CA19-9 greater than 98. And here again, we saw a similar trend where neoadjuvant therapy demonstrated survival advantage over adjuvant therapy with a higher CA19-9 level in these clinical stage 2 patients. In conclusion, the perioperative therapy is associated with improved survival in early stage pancreatic adenocarcinoma that undergoes resection, irrespective of the CA19-9 level. Neoadjuvant therapy is associated with improved overall survival for early stage pancreas cancer only with a CA19-9 greater than 98 versus those patients who receive adjuvant therapy. There are obviously limitations with this study. There are multiple randomized controlled trials that have been looking at these early stage pancreas cancers, and here we are performing a retrospective analysis, whereas lends itself to selection bias. And importantly, we are unable to account for those patients who are unable to undergo surgical resection because they are excluded in the neoadjuvant therapy and perioperative therapy cohorts. And we are unable to define the indication for the therapeutic sequence within these patient cohorts as well through the NCDB. The NCDB itself is an excellent resource, but the chemotherapeutic regimens that are used are not well defined other than multimodal versus single agent chemotherapy. So we can't tell whether it's gemcitabine-based therapy, FOLFIRINOX-based therapy that were used in these patients, and the type of radiation that was used. But we can look at the timing of those therapies, including radiation. In the future, we hope to look at the type of therapy, whether it's single agent or multi-agent chemo in these neoadjuvant and perioperative cohorts, as well as the radiation used in these cohorts, and see whether we can stratify those patients even further into those who derive a survival benefit. The propensity analysis of clinical stage 1 and 2 independently is difficult because of the size discrepancy between cohorts, so it's difficult for us to attribute for the differences in the covariates. But if we can find a way to include those, we will moving forward. And lastly, the pathologic characteristics at resection would be important to review, as we would be able to see how the null status was after resection in these patients, which we know confers a significant difference in overall survival. And that's it. I appreciate your time. Thank you.
Thank you. Everything comes to the mic. For those of you who are in the back, there are exceptionally comfortable seats in the front here, so I invite you to come up and enjoy.
Tim Moisong and Anderson, thanks, Dr. Richards, for your nice delivery of your talk. So what you're getting at is the most common issue, I think now, induction chemotherapy is likely the standard for all phases of surgical pathway, I would say pancreas cancer. So you're asking about perioperative. So you looked at 98 as your cutoff, and this may be hard to answer with NCDB, but in your opinion, surmising, does it matter if it's not 98 cutoffs at diagnosis, right at the time of surgery, or if you get to 98 after surgery? That's question number one. And number two, is there any stage of pancreas cancer that you would not aim for perioperative chemotherapy from what you've seen here? Is there not, should that be a goal for all patients of all stages? Thank you.
Thank you. For your CA19-9 level question, the way that it's reported to the NCDB is at diagnosis. So all these values that are attributed here to the survival is based on a diagnostic CA19-9. Unfortunately, there's no longer collection of CA19-9 through the NCDB, and there's a shortened window where CA19-9 was accurately collected. So this data actually only looks at a period of time from 2010 to 2015. For your second question, I think we hesitate to give any treatment recommendations specifically based on this data, given this retrospective design. But I think our propensity score analysis allows us to hypothesize that patients who receive and complete perioperative therapy will benefit, will have a survival advantage regardless of their clinical stage, whether it's clinical stage 1 or 2.
Dr. Arman.
Thank you, and congratulate you and your co-authors on a great project and presentation. Because I was surprised that there was no difference between that there was a difference between perioperative and neoadjuvant. I would have, without seeing the data, expected those two curves to be going to happen. I think at least, you know, how I look at this in terms of comparing those two arms to the adjuvant is that's a denominator effect. You're not getting, you're not capturing the denominator with an NCDB database. So one of the things that to explain the difference between perioperative and neoadjuvant, I wonder is whether the number of cycles being given. If someone got one cycle of chemotherapy, that would be considered neoadjuvant. And then maybe they're not getting adjuvant therapy because of performance status or things like that, where someone got 3 to 4 cycles, several months of it pre-op, and additional, so it's a total dose density. And that's a concept that we all need to understand. It's not whether it's neoadjuvant or adjuvant, but really dose density, mixed cycles, decrease in dosing. So those are important concepts to understand when looking at these data. And I wonder if you could just kind of comment on that, because the field is heading towards total neoadjuvant therapy. And that's how the clinical trials are designed. And so your data is in conflict with where the field is heading. So I wonder if you can comment on that.
Thank you for your question. My understanding through the NCDB is that we are evaluating patients who completed at least 4 cycles of therapy. So the neoadjuvant therapy that they're getting up front may not have been a complete course like you suggest. And so we may not be capturing truly those patients that receive total neoadjuvant therapy. I think the pre-op PANC-2 trial will help us delineate survival advantages between the two. Although it will be looking at 2 different systemic therapy regimens, including modified FOLFIRINOX versus gemcitabine combined with radiation. But to your point, you're exactly right. It's hard to be able to account for those differences through an NCDB analysis.
So we have time for one additional question. Please be brief and please respond briefly.
Also, good Koerkamp by Rotterdam, Netherlands. Congratulations with your research, and thank you for having good hopes for PREPANC-2 results. I just want to make one comment. We just combined the PREPANC-1 data with the Korean trial, and we looked at a similar question. We looked whether the treatment effect of neoadjuvant treatment differs for high and low C99, and the answer was no. So whether your C99 is high or low, the treatment effect of neoadjuvant treatment is the same.
Okay, thank you.
Thank you very much. Taker is mentioning back the relation predicts additional risk for malignancy from the buccal positive IPMN. We represented Montreal, Massachusetts, and discussed on results of Canada. NIMS Hospital and Cancer Institute.
Hi, everyone. My name is Alan Yang, and I'm excited to present our findings on the significance of unstint duct dilatation in evaluating IPMNs for the risk for malignancy. An important area of pancreas research is understanding which IPMNs warrant surgical resection. That is, which IPMNs harbor the greatest risk for developing high-grade dysplasia or invasive carcinoma, which I will refer to in this presentation as malignancy. The Fukuoka consensus criteria summarize many of the known risk factors used to stratify lesions based on their imaging features. Perhaps the most salient risk factor is main duct dilatation, which, as a harbinger of a main duct IPMN, increases the risk for malignancy by over 5-fold. In contrast to main duct dilatation, unstint duct dilatation has not received as much attention. Although the unstint duct is considered a branch duct, it actually originates as the primary duct of the ventral bud, which fuses during gestation with the dorsal bud to form the mature pancreas. Therefore, it has been hypothesized that unstint duct dilatation is also associated with malignancy, just like main duct dilatation. Two prior studies from Memorial Sloan Kettering and the University of Pittsburgh have alluded to a potential association between unstint duct dilatation and malignancy. Hence, we wondered if we would find a similar association in a larger cohort at the Massachusetts General Hospital. So we performed a retrospective cohort study of patients who underwent surgical resection for IPMNs. In total, 467 patients met inclusion criteria, which included having at least one Fukuoka risk factor. Imaging data was collected by HPV radiologists blinded to the patient's pathology results. As in previous studies, we defined unstint duct dilatation as greater than or equal to 4 millimeters. We used multivariable logistic regression to analyze the association between unstint duct dilatation and malignancy, both across the entire cohort and among the 194 patients without any cysts in the head of the pancreas. So these are patients with branch duct IPMNs and the neck, body, or tail only. In our cohort, the mean age at surgery was 70 years and 49% of the patients were female. Across the cohort, 57% of patients had only Fukuoka worrisome features, while the remaining 43% had at least one high-risk feature. Unstint duct dilatation was present in 35% of patients, of whom 73% had malignancy. In fact, this bar graph displays the prevalence of malignancy in different subgroups of patients, each then further subdivided into those with or without unstint duct dilatation. What I want to draw your attention to is the finding that the prevalence of malignancy in all patients with unstint duct dilatation was 73%, which was similar to the 74% in patients with high-risk stigmata and the 73% in patients with main duct IPMNs. To test whether unstint duct dilatation was associated with malignancy, we constructed a multivariable logistic regression that adjusted for the presence of at least one Fukuoka high-risk feature, thereby stratifying those patients out from those who only had worrisome features. And even after this adjustment, the presence of unstint duct dilatation was associated with a 2.8 higher-fold odds for malignancy. And here we plotted a version of this regression model to demonstrate that our model is actually well calibrated to the raw data. The data series on the top shows that the odds for malignancy as the size of the unstint duct increases in patients with at least one high-risk feature. And the data series on the bottom is for patients with worrisome features only. And in both cases, unstint duct size predicts increased risk for malignancy. Next, we wondered whether this association would still hold if we looked at patients without any evidence of a cystic lesion in the head of the pancreas. This analysis was inspired by previous literature that had shown such an association in this kind of subset of patients. And among the 194 patients with branch duct IPMNs in the neck, body, or tail only, we constructed a similar regression and found that unstint duct dilatation increased the odds of malignancy by 3.2-fold in this subset. This was an interesting result because it suggests that unstable duct dilatation somehow predicts malignancy, even when the only cysts the patient had were far away from the unstable process. What's even more interesting is that many of these patients underwent a distal pancreatectomy, meaning that the malignancy itself was found somewhere quite far from the unstable process. We explored this observation further by returning to the entire cohort and testing the association between unstable duct dilatation and malignancy in patients who had their pancreas head resected, so lipo or total pancreatectomy, versus in those who did not. And in both subgroups, unstable duct dilatation was still predictive of malignancy. All these findings suggest that whatever process is going on in the unstable duct seems to relate to the development of malignancy in the rest of the pancreas. It's hard to explain how a dilated unstable duct could be associated with cancer elsewhere in the pancreas, but we speculate that this could be explained by a field cancerization effect, which posits that the development of malignancy in IPMNs is a multifocal process that reflects an overall elevated risk for cancer across the entire pancreatic ductal system. In that vein, unstable duct dilatation could be interpreted as a harbinger of malignancy across the entire pancreas potentially. Future studies with more granular pathologic findings and molecular genetic studies are needed to understand what unstable duct dilatation represents and what its relationship is with malignancy across the entire pancreas. So to summarize, unstable duct dilatation predicts additional risk for malignancy that is not accounted for by current Fukuoka criteria. Patients with unstable duct dilatation in the setting of other worrisome features appear to have a similar risk for malignancy as a main duct IPMN or a Fukuoka high-risk IPMN. Hence, when observed in the presence of other risk factors, unstable duct dilatation may be considered a high-risk feature or like a high-risk feature that warrants surgical resection. Nevertheless, this study cannot tell us what the significance of an isolated finding of unstable duct dilatation is in Fukuoka negative patients, since all the patients in our cohort already had a pre-existing indication for surgery. We suspect that an isolated finding of unstable duct dilatation would increase somebody's risk for cancer, but future investigations in a surveillance cohort are needed to know for sure. Thank you so much for your attention. I also want to say very much thank you to the amazing collaborators and role models that I got to work with, including Dr. Lilimo, Dr. Kadan, and Dr. Fong. It's really an honor as a medical student.
Ridiculous presentation of this really important work. And thanks also for providing me with the manuscript. Not many students earn the opportunity to present at a national meeting, so congratulations, very well done. Thank you. To summarize, dilatation of the main unstable duct is not considered, as you said, to be a risk factor in the Fukuoka guidelines. Yet you and other groups have wondered if the unstable duct might better be considered as another main duct, and if therefore, when dilated, it might pose a risk similar to main duct dilatation in the dorsal pancreas. And you found indeed that unstable duct dilatation does confer risk similar to dilated main dorsal duct. Indeed, it increased the risk of cancer dysplasia by nearly threefold, with resultant prevalence of 70%, essentially the same as in patients with high-risk stigmata or main duct IPMN, generally resected. This work, as you mentioned, builds nicely on supports two previous studies. Peter Allen from Memorial first made this observation in 2014 in a paper first authored by John Mori, and then last year, Almasari and Zurkat UPMC published this for seminars. That UPMC paper also showed that in IPMNs confined to the dorsal portion of the glands, unstable duct dilatation was a significant predictor of dysplasia or cancer, even in those remote lesions. And you confirm that finding also in your study. So I have a few questions. First, about cutoffs. How did you determine that? For example, regarding the 4 millimeter cutoff, your rod curve in the manuscript shows that compared to high-risk stigmata, the 4 millimeter cutoff increases the sensitivity but decreases the specificity. And it seems like the sweet spot is around 4 to 4.5 millimeters. What is the area under your rod curve? Basically, can you comment on the choice by your group and the previous groups for that cutoff of 4 millimeters? And speaking of cutoffs, regarding the cutoff for the pre-op scans, you mentioned in the manuscript that was within 2 years. And although most of those scans were done much closer to the time of the operation, as you'd expect, there were some going out from 6 to 24 months. And I was wondering if you did any subgroup analysis to see if there's anything different about those patients with older scans. If you excluded those older scans, how much the results have changed. And also incident duct dilatation increases the risk. But incident cysts per se don't. And by incident cysts, then I assume you mean branches of the main uncinate duct that are cystic and not a focal dilatation or enlargement of the main uncinate duct. Just want to confirm that's correct. And then finally, and you touched on this a little bit, why do you think that uncinate duct dilatation is predictive of cancer dysplasia anywhere in the pancreas, not just in the uncinate duct? What biologically is behind that field cancerization effect or field effect? And how does uncinate duct dilatation specifically fit into that effect?
Thank you very much. So this is the ROC curve that you were referring to. I don't know the area under the curve off the top of my head, but as you can see, if you take the bottom point, that's the patients with types features, and if you add uncinate duct dilatation at these different cutoffs as the fibers change, this is how the sensitivity and specificity changes. And so the cutoff we borrowed from previous literature, but even in our analysis, a cutoff of around 4.5 does give you the highest accuracy, closest to the top left corner of the graph, but I'd have to get back to you on that area. And the question about uncinate cysts, that's right. It means that a cystic lesion that was observed coming off the uncinate duct. And then the last question was cutoffs. Oh yeah, we didn't do that subgroup analysis, but happy to talk with you later. More than 95%, I believe, of patients had a scan within 6 months. So I don't think that if we took the 5% and had one later, that our results would change that much. And then to your fourth question about the field cancerization effect, it's hard to know exactly what's going on. I don't know, I'm a medical student, so I suspect that maybe one explanation could be that during embryological development, there may be genetic changes in the common embryological precursor to the biliary tract into the pancreatic ductal system that then predisposes that entire system potentially for higher risk for cancer, maybe like a DNA mismatch repair, something like that. That's going on that then predisposes those cells to malignant transformation. There was one study that showed that the linear rate of cancer in the population, both in the for biliary ducts and for pancreatic cancers, is the same, even though the actual prevalence is different between them. The progression as you age, that rate of growth is the same, which also suggestive of a field cancerization effect that involves that entire system. But we'd have to do more studies to know for sure. I think that is it.
Congratulations, very interesting study. I just have something of a small comment. Another possibility is that the uncinate duct dilation, separate to a known cyst somewhere, let's say in the body of the tail pancreas, is due to increased mucin production, possibly by the other cyst, and maybe that leads to some area almost sludge of the pancreatic effluent. And possibly to one thing to look out for is if postoperative imaging studies, surveillance MRIs or whatever, were to show a decrease in uncinate duct dilation, maybe it is clearly due to the original cyst and not something going on the uncinate.
Yeah, that's very fair, and we wondered about that too, which is why we did that analysis looking at uncinate cysts and also and in comparison or in contrast to uncinate duct dilatation. I think more work probably needs to be done in order to fully differentiate between the two. And sometimes our ability to differentiate between the two based on imaging was limited by the quality of what you can see on imaging. But because uncinate cysts themselves were not associated with malignancy, but the uncinate duct dilatation, at least such that was observed by the radiologist in our study, was associated with malignancy. We tend to think that uncinate duct dilatation is something different than simply having an uncinate cyst and means something different.
Very much.
I have a final question. Were you able to analyze the rate of dysplasia present in the duct itself according to the dilation? Because what the doctor said about the passive or active dilatation of the duct, if you have measure of the risk of malignancy in the duct itself, not the whole malignancy in the duct.
So
The grade of dysplasia fluorescent in the duct, in the uncinate duct cell.
yeah,
Could you analyze that
yeah, that's a great question.
regarding the diameter of the duct and the possibility of high grade dysplasia
In the duct itself.
in the duct itself?
Yeah.
Hold this.
Yeah, so we didn't have data in the pathology reports about where exactly they found hybrid dysplasia, which is why we did that kind of workaround subset analysis, looking at those with pancreas head resection and those with distal pancreatectomies. I think that could be a really great future study, though. Yeah, that's something we thought of.
Thank you very much.
Patients infected missing precision measures to stimulate anti-tumor immunity, and by John, immune Oxford, that's going to be John. Rejected that. Sorry, you're stimulating.
Department of Surgical Science at the University of Oxford. I'm going to talk to you about macrophages in pancreatic cancer. I don't have any conflicts. So everyone's probably sick to death of seeing these pictures where we show pancreas cancers full of stroma, non-cancer cells, particularly things like fibroblasts and macrophages. Conventional systemic therapies are historically designed to target the epithelial compartments of the tumor cells, but we know that the other cellular populations are important in conferring treatment resistance. So when it comes to immunotherapy, we're obviously as HPV surgeons very jealous of the other solid tumor surgeons who got great results when it comes to immunotherapy, particularly things like melanoma, non-small cell lung cancer. When it comes to pancreas cancer, we know that immunotherapies are useless in most patients. Some patients in very specific settings are sensitive, and so we know that it's possible and achievable. But unfortunately, most of our pancreatic cancer patients fit in that middle of the road where they have dense stromal reactions, heavy infiltrating immune suppressive cells. So we need to think about new and multimodal approaches to try and tip the balance in favor of anti-tumor immunity. We know that anti-tumor immunity is a stepwise process, and you don't have the antigen available. They need to be presented. You need to get T-cell priming. The T-cells need to get into the tumors, culminating in an effective anti-tumor cytotoxic T-cell response. But in pancreas cancer, there's a barrier at almost every stage, and so it's a real challenge. What we've postulated preclinically is by introducing tissue injury to increase local inflammation, combined with reversal of immune suppression by targeting the macrophage myeloid compartment, which are one of the main culprits of local tumor immune suppression, we would hopefully tip the balance in favor of anti-tumor immunity. So for the tissue injury, we're using ablative doses of radiation. So this is either 1, 2, or 3 fractions, ranging from 6, 13 up to 25 gray, and a selective small molecule inhibitor targeting a pathway in macrophages. Everyone's familiar with how we deliver SBRT in pancreas cancer, but in terms of the macrophage selective targeted agent, we're looking at the gamma isoform of the PI3 kinase pathway. The nice thing about this is it's delivered systemically, but it only targets the myeloid compartment because that isoform is only present in myeloid cells. I'll talk a little bit about the pathway. Signaling is not my favorite thing, and this is as simplified as I can get it. We have extracellular stimuli, cytokines. They engage with receptors on the surface of macrophages. And downstream of this, the PI3 kinase pathway, when activated, results in a transcriptional profile which reflects in an M2 phenotype, M2 being a pro-tumorigenic phenotype, and they're the predominant population in most solid cancers and certainly in pancreas cancer. The M1 side, on the other side, activated by the NF-kappa B pathway, is the archetypal inflammatory monocytes, which would promote anti-tumor immunity and a T-cell response. In cancer settings where we have an abundance of extracellular cytokines, there's a perpetual stimulation for macrophages to persist in an M2 state. So by blocking the pathway, binding it with radiation, we'd hope that the further increase in extracellular stimuli induced by radiation, combined by blocking that pathway, would result in an M1 activated state. In order to determine that we have macrophages with pathway, so the PI3K gamma gene present, we've harmonized the data from some publicly available single-cell sequencing data sets that you'll be familiar with. then deconvoluted to get the immune cell populations and stromal populations. When we further compartmentalize those to look at specific immune cell subsets, we can see the macrophage monocyte compartment in green, and we can see that there's PI3K gamma clustering. You'll notice that it's also present in the T cell subset. Fortunately, the T cell subset has a predominant dependence on the delta isoform of the pathway, so they are affected by delivering the drug. And when we look specifically at the macrophage cluster, we can see an abundance of the gene expression of PI3K gamma. So we tested preclinically. We use an orthotopic model of pancreas cancer, direct injection of a KPC clone to the pancreas, and then monitor the tumor volume, delivering stereotaxis or SBRT radiation at different doses, combined with a daily oral PI3K gamma inhibitor. Here are some representative MRI images of monitoring tumor growth over time, and then we use a small animal radiation research platform to deliver the radiation stereotactically. In terms of what happens to tumor growth, so on the left-hand panel, we can see a dose of 3 fractions of 4 gray, where we initiate tumor treatment when the tumor volume reaches 100 millimeters cubed. So that's when it's on the exponential growth phase, reminiscent of the sort of locally advanced that's rapidly progressing. On the right-hand side, we have 3 doses of 6 gray, initiated when the tumor volume is 30 millimeters cubed. This is the pre-exponential phase, more reminiscent of a borderline resectable or a resectable patient. And we can see what's interesting. We know that radiation and the drug alone has very little effect, and the mice eventually succumb to primary tumor progression. However, when you combine it with the drug in both settings, we get control of the primary disease. The mice then live longer, but do eventually come to dissemination and metastases. So what's happening? We get this significant improvement in survival despite eventual progression. And when we compare it to radiation alone, it's a relative increase in survival about 50%, but compared to treatment, no treatment, it's a significant elevation in survival. When we look at what happens in terms of metastases, so these mice have got primary tumor control. When they finally succumb due to metastases, the primary tumor is not increased in its volume, so they're dying from metastases. And one of our oncologists made the point that we should clarify that we're not promoting metastases by delivering a combined inflammatory and radiation agent. So we fluorescently label some tumor cells. We can see here a primary in situ, and we're able to get good images using iris imaging. We can see that in untreated animals, this is where the primary's been resected. We can see widespread dissemination and metastasized to the liver, lungs, diaphragm, peritoneum. And we can see when we look at our radiation versus a radiation plus treatment, there's no significant difference at a snapshot time point of metastatic dissemination. In terms of what's happening locally, histologically, we can see in the combination treatment group, a striking difference on H&E sections. These are all at the same time point. Once we look at a 20x shot of the combination versus radiation alone, we can see a loss of epithelial cellularity and a significant change in stromal compartment. Looking at trichote staining, the blue showing collagen, we can see a significant loss of that stromal compartment in the center of these tumors. What's interesting is these areas of necrosis have got cellular content, that those cells are immune cells, and here we can see multiplex IHC demonstrating an infiltrate of CD8, NK, and some granulocytic neutrophils. When we disaggregate and look at the tumor cell subpopulations by flow cytometry, we can see a reduction in the suppressive version of monocytes, MDSCs, and a significant increase in the CD8 T cell compartment. You'll notice that in both radiation groups, the T cells are lower than in the untreated or monotherapy. When we deliver radiation, we significantly reduce the number of CD8 T cells. But what's interesting is we do achieve tumor control, which would suggest that the CD8 T cells, when you've got radiation in the mix, are more tumor specific. And we've got some data to suggest that this may be a CD8 mediated phenomenon. When we look at where they are throughout the tumor, if we take a whole tumor section, the staining corroborated what we saw on flow cytometry. But importantly, those CD8 T cells are present in the center of tumors, not just along the periphery. What's interesting is why have we got more macrophages, more CD8 T cells? We know that we've got increased cytokine production, which is recruiting CD8 T cells from the periphery into tumors. But also, when we just take macrophages, MDSCs, and T cells and put them in the lab and it's treatment, we know that the treatment reverses the suppression capacity of macrophages to suppress CD8 T cell proliferation. And then finally, an unbiased approach where we take chunks of tumor sequence them. We can see that
the top three most significantly enriched pathways on GSEA analysis are allograft rejection, interferon gamma response, and inflammatory response, which would support further increases of local tumor control. To confirm to what extent the effect is dependent on CD8 T lymphocytes, we repeated the experimental model in the absence of T cells. So we deplete T cells in these incompetent mice before starting any of the therapy. And the treatment is not only abrogated, they actually grow even faster in the combined when you deplete CD8 T cells. So obviously we asked ourselves the question, having set out on this approach, does having further increased CD8 T cells present within the tumor augment any potential benefit to anti-PD-1, one of the more well-recognized immune checkpoint inhibitors? And when we combined anti-PD-1 with a combined approach, we didn't see any additional benefits. So these mice still developed metastases and there was no control. I suspect that's because we've selected the most frequently available, most well-recognized immune checkpoint inhibitor, but we know there are in excess of 25 checkpoints, all now with available preclinical agents to test. And so that needs some further development. So our future work, we've got the Emerald trial just closed in Oxford, which has done a dose escalation of MR-Linac ablative radiation. So we're going to add on an arm in a second trial to do a dose escalation of 25 gray, 3 times 13 gray with the drug as an oral agent. And that would be in locally advanced pancreatic cancer. We'll do a checkpoint screening experiment using human avatars to try and decipher which might be the best combination approach. And then finally, we need to do some more preclinical experiments exploring the priming mechanism of the T cells. Thanks.
Well, thank you very much, Dr. Jones. This is Josh Stoddard from the University of Miami. I want to thank you for this wonderful talk and the HPV for giving me this opportunity to discuss a topic very close to my heart, which is myeloid immunobiology and pancreas cancer. So just as a summary, the premise of this study leverages lessons learned in multiple cancers, actually, where PI3K gamma subunit inhibition has been employed to target the alternatively activated fate of macrophage polarization, which is the immunosuppressive fate. To induce sensitivity to immune checkpoint blockade. That's what's happened in melanoma and other cancers. And it's an attractive target, as you showed, because it's preferentially expressed in the myeloid compartment, and mice deficient in the P110 gamma subunit actually have arrested tumor growth and reduced immunosuppressive myeloid populations. And here you show, using hypofractionated RT and PI3K gamma inhibition, that there's tumor arrest and immune invigoration. However, it doesn't sensitize to immune checkpoint blockade, which is an interesting observation. So with this background in mind, I have 3 questions for you. I think everyone in this room is dying to know what the predominant phenotype of the tumor-infiltrating T cells are. And you talk about proliferation, but not really the function, which may explain why you're seeing differential effects when you have immune checkpoint sensitivity. Does the PI3K gamma inhibition in the myeloid compartment actually increase the cytolytic capacity of the T cells? And if so, are these mechanisms directly related to the M1 feed, which is just better antigen presentation, or is it indirect mechanisms through MDAC, as you suggested?
Yeah. You can take that first if you like. Thank you. Thank you for your comments and the questions. Extremely insightful questions. So in terms of the CD8 specificity, in terms of the cytolytic capacity, it's obviously challenging to determine that in vivo. We have got some ex vivo experiments where we take the cells out and then implemented them in a in vitro cytotoxicity assay. And those early results are showing an improved interferon gamma response, CD20, CD62 ligand, and CD44, so an effector memory type, and then also CD69. So all of those markers indicative of an effector memory type T cell activity are increased. I've just isolated the T cells from the tumors and had a message yesterday saying they've got good RIN values and they'll be sequenced in terms of trying to determine the phenotype. I think in terms of the PD-1 and the exhaustion markers they're expressing, I can't think of any published preclinical reports demonstrating effective anti-PD-1 therapy in mouse models of pancreas cancer. So it's a poor target. The problem is, in terms of thinking about the translational element of trials, if we were to target a random checkpoint that has no clinically available drug, we need to think carefully then about how we progress. So it's a balance between picking something that has therapeutic benefit and is expressed in our T cells. Have I addressed those questions so far?
Yeah, very insightful response. We should talk after about in vivo T cell monitoring. We have a transaminase nano reporter that you can, so we'll talk. My second question gets to that you know, it's interesting you chose to conduct your studies without chemotherapy. And, you know, if you're moving towards a trial, like I saw with the locally advanced populations, we are to conceive a trial where you don't have a chemotherapy backbone. So have you looked at chemotherapy combinations with and without?
So before I got the assistance of those students in the lab, I was slowly dying of doing these experiments, and I couldn't include chemotherapy arms because it was just too much work for one person. But now going forward, I should be able to introduce those arms, and they are important. The Emerald trial, actually, we don't have any concurrent chemotherapy because it's the course of radiation is over 1 week. Right. So what I'm pushing for as a surgeon is a window element to the trial. So we give our 3 fractions or a single fraction, give the drug, and then resect, not after say 3 months in the neoadjuvant window, but resect fairly early after that. So we get a nice specimen for analysis. So that's the current thinking in terms of the trial.
And my final question is that, do you have time or?
So.
Very briefly.
Very big question. You talked about fibroblasts. Myeloid cells impact stromal inflammation and fibroblast polarization. Did you look at the fibroblast compartment? Beautiful work. Thank you very much.
So in terms of the fibroblast compartment, what we're currently doing is a separate set of experiments with some collaborators looking at the in vitro, where we can just separate out the macrophages with and without treatment, having been exposed to cancer cells, and their effect on the fibroblast phenotype, looking at ICAF switching. And those experiments will happen over the next few months. Thanks.
Thank you very much. We have the last paper, the optimized surveillance intervals for low risk side branch intraductal capillary IPM. The presenter will be Dr. Saul from MD Anderson, and the discussion will be Dr. Amin.
Good afternoon, everyone. Thank you for being here today, and thank you to the AHPBA Program Committee for the opportunity to present. I have no relevant disclosures. Intraductal papillary mucinous neoplasms, or IPMNs, are mucin-producing papillary or flat epithelial neoplasms arising from the main pancreatic duct or its side branches, and may progress through the adenoma carcinoma sequence of malignant transformation, with rates accumulating to 5 to 20% over time in side branch IPMNs. Furthermore, they are also thought to represent a field defect that increases risk of malignancy at other sites in the pancreas. The 2017 Fukuoka International Consensus Guidelines identified 3 high-risk stigmata and 9 worrisome features for which resection or further testing is recommended if identified during surveillance. We believe side branch IPMNs demarcate a population of patients at higher risk of pancreatic cancer and can be followed for early detection of pancreatic malignancy from or external to the cyst itself. In the absence of worrisome features or high-risk stigmata, side branch IPMNs less than 2 centimeters, which are considered lower risk lesions due to their size, may undergo surveillance at varying intervals. Recommendations from different consensus guidelines are shown on this slide. As you can see, recommended intervals vary from every 6 months to every 2 years, and the length that is recommended varies as well. We had 2 primary questions with our study. The first was to assess the rate of significant changes, which we defined as new high-risk stigmata or worrisome features, resections, and malignancies in side branch IPMNs less than 2 centimeters at our institution under our current protocols for surveillance. The second was to determine if these intervals could be changed to maximize early detection and treatment of pancreatic malignancy while minimizing unnecessary visits and tests. To do so, we queried our prospectively maintained pancreatic cyst clinic database to identify all patients with side branch IPMNs less than 2 centimeters. After excluding 33 patients that had less than 6 months of follow-up, we ended up with a total of 286 patients in our study. Patients were usually seen within 6 months after their initial presentation, and then followed either every 2 years for a cyst less than 1 centimeter, or yearly for cysts between 1 and 2 centimeters, with either CT or MRI abdomen. Clinical and imaging data at initial presentation in 1, 3, and 5 years thereafter were analyzed for qualitative cyst changes, surgical intervention, and malignant transformation rate. Of the 286 study patients, approximately 60% were female with a median age at first visit of 69.5 years. No cysts had high-risk stigmata or worrisome features at baseline. Patients were followed for a median of 26.7 months with minimal change in median cyst size. There were no statistically significant differences in cysts 1 centimeter or less or between 1 and 2 centimeters. In the cyst 1 centimeter or less group, 4.5% developed new worrisome features during surveillance, while 14.2% developed new worrisome features in the 1 to 2 centimeter cyst group. A total of 6 cysts were resected, 1 in the less than 1 centimeter group, and 5 in the 1 to 2 centimeter group. Of these, 4 were malignant non-surgical pathology, with an equal split between non-invasive high-grade dysplasia and invasive ductal adenocarcinoma. In addition to the 4 malignant resected cysts, 2 additional locally advanced adenocarcinomas were diagnosed in the 1 to 2 centimeter cyst group. There were a total of 6 malignancies. A swimmer's plot of the 30 patients with new worrisome features plus 2 cysts resected without significant changes can be seen on this slide. Each line represents an individual patient with dark gray representing cysts less than 1 centimeter on the bottom and light gray lines representing cysts between 1 and 2 centimeters. Each symbol represents a new worrisome feature, malignancy, or resection. The previously discussed 6 resected and 6 malignant cysts are represented by orange and blue circles. Changes at 1 year after initial visit are shown in red. At this time point, 2% of cysts less than 1 centimeter and 5% of cysts between 1 and 2 centimeters develop new worrisome features. At 3 years after initial visit, represented by green symbols, an additional 4% of cysts in the less than 1 centimeter group and 13% of cysts in the 1 to 2 centimeter group develop new worrisome features. Additionally, 3 malignancies were diagnosed by this time point. Of those who were followed for up to 5 years, represented by purple symbols, 5% of cysts less than 1 centimeter and 13% of cysts between 1 and 2 centimeters developed new worrisome features, and another 2 malignancies were diagnosed. The 6th malignant cyst was diagnosed after the 5-year mark at 7.8 years. And the most common new worrisome feature during surveillance was growth of 5 millimeters or more within 2 years, as evidenced by the triangle symbols. Of the 6 patients diagnosed with malignancy, which we defined as high-grade dysplasia or adenocarcinoma, 5 developed worrisome features that were noted at scheduled surveillance visits. Among these, all had cyst growth of 5 millimeters or more within 2 years. 3 had main pancreatic duct dilation between 5 and 9.9 millimeters. 2 had CA19-9 levels above 37 units per liter, and 1 had a solid nodule less than 5 millimeters. Only 1 patient had cyst growth as the only new worrisome feature during surveillance. Patients who developed worrisome features at any point during surveillance were more likely to receive endoscopic ultrasounds and fine needle aspirations, as well as be resected or be diagnosed with malignancy. However, when only cyst growth was assessed, patients were more likely to receive the previously mentioned procedures, but they were not more likely to be diagnosed with malignancy. In conclusion, let's revisit the 2 questions we discussed at the beginning. For our first question, we determined that new worrisome features developed in 10.5% of cysts less than 2 centimeters at our institution, with a higher proportion occurring in the 1 to 2 centimeter group. These lesions, which we call dynamic cysts, are at increased risk of malignancy and represent a higher risk subset in an already high-risk population. For our second question, regarding optimized surveillance intervals, we believe that our surveillance protocol is optimized for the majority of our cohort, which were patients that did not develop new worrisome features during surveillance, or what we termed static cysts. In this subset of 256, only 1 developed malignancy, which could be considered a miss rate of 0.4%. This is comparable to that reported for mammographies and lower than what is reported for colonoscopies. Our next step will be to assess whether shorter intervals of surveillance or alternating imaging modalities in this subset will lead to fewer or earlier malignancy diagnoses or improved survival. Thank you all for your time today, and I'm happy to take any questions.
Got a well-presented paper, and I want to thank you for sending me the slides ahead of time. So I was struck by the number of patients that actually had a change within a short amount of time for subset of patients with small cysts. So I was struck by the high number of people that demonstrated change in 1 year's time. And we know that a group from Indiana, I think, well represented in this room here, published data on the accuracy of the revised proposal worrisome features. They demonstrated the difference between radiographic features and clinical features with respect to accuracy over time. So based on this, can you describe whether these changes that were detected in a short amount of time, i.e. 1 year, were in fact changes, or were they just a reflection of the modality of imaging or the radiologist that was looking at it? Second question is, based on your presentation, I'm still unclear what the indication for surgery was for these patients. So some of them developed a single worrisome factor but went to surgery. And I think many people would continue watching only one worrisome patient. Can you comment on what your indication for surgery was? We in the Central Pancreas Consortium have demonstrated that having multiple worrisome features is equivalent to high risk feature. This was corroborated in a paper recently by the MJH group. Could you comment on how many patients had multiple worrisome features, and did that equate to a higher incidence of invasive cancer? And then again, the MJH group and the Verona group, who's also representing this group, have demonstrated that small cysts after 2 to 3 year follow-up have a very low incidence of progression. And so again, your median follow-up is a short amount of time. What happens to these cysts past 2 to 3 years? Do they have an initial increase and then they stabilize? And or do they continue to improve this dynamic cyst group that you're talking about? Thank you very much. Well presented.
Thank you very much, Dr. Ahmad, for reviewing my presentation and also for your questions. So with regard to your first question regarding whether the changes noted at the first or third year visits were due to differences in image modality or different radiologists reading it, or if they were actual changes. Most of our patients used the same imaging modality during surveillance, although there were differences with more patients who had either CT 1 year and an MRI a different year or a different reading radiologist. However, I went through and also made sure that all of the changes that we saw, whether it was shown or new nodules, were corroborated both on my review and both my review of the imaging and my review of the piece of the imaging itself. In regard to your second question, in terms of what were the thought processes leading to surgery. So I think this is a good representation of kind of what factors led to operating. So if you look at the orange circles, which demonstrates resection, most of them are preceded by some new worrisome feature in this Summers plot. So most of them did have either at least one or usually more than one new worrisome feature that helped lead to the decision for surgery. Although there was 1 or 2 patients who did not have any significant changes prior to resection, and that was usually a multifactorial decision-making process between the patient and the medical team. And then in terms of your third question about multiple worrisome features, so actually what we found was pretty consistent with what was found by the Central Pancreas Consortium, which is that of those who had malignancy, most of them had at least one or more worrisome feature, which is consistent kind of with what you guys found as well. So we found that of those who had more than one worrisome feature, which was about 1 in 6 in our cohort, they were more likely to be diagnosed with malignancy. And also in the case of our 6, more likely to have invasive adenocarcinoma versus non-invasive high-grade dysplasia. And then with regard to your question about long-term follow-up, so our median follow-up time was shorter. However, we did follow a subset of patients up to 5 years or more. And we found that the rate of new worrisome features was still elevated at about 13% in the 1 to 2 centimeter cyst group. And this is actually consistent with the studies published from MGH in Verona that showed that about 1 in 6 had new worrisome features in the past 5 years of surveillance. So we would recommend that they probably do need longer term surveillance.
Thank you, Dr. Zhao. So on behalf of Dr. Mazza, my co-moderator, thank you all for attending this session. Special thanks to the speakers for excellent presentations and to our discussants for insightful views. We have the presidential address is currently ongoing right now, so please go ahead and join in Americana. Thank you.
Thank you.